and good afternoon, everyone. My name is Tara Satlow, and I'm the Director of Client Solutions at the Leadership Development Group, or TLD Group. For those of you who may be new to TLD Group, I'd like to take this opportunity to introduce the firm and explain our mission and purpose. We are a global healthcare talent development firm, working with leaders, teams, and organizations across the healthcare ecosystem, including providers, payers, and pharmaceutical companies, to enhance an executive's ability to execute strategy. TLD Group builds customized solutions with and for our clients, including results-oriented leadership assessment and coaching, high-performance team development initiatives, strategic succession planning programs, and executive, physician, and group leadership academies, including our Applied Physician Leadership Academy, APLA, and our Applied Collaborative Leadership Academy, ACLA. Our academies are designed to engage and empower leaders, dyads, triads, and teams to take on the leadership challenges facing their organizations, their sectors, and the industry. Our worldwide faculty of over 200 organizational development practitioners, academicians, coaches, and consultants with deep expertise across the healthcare industry enables us to offer targeted insights and deliver highly impactful results. As part of our commitment to the healthcare industry, we are proud to introduce our health ecosystem leadership model, built through our survey research with and consulting expertise within the payer, provider, and pharmaceutical sectors. Our model focuses on the key capabilities leaders require to truly transform the health ecosystem by enabling cross-sector collaboration. So be sure to stay tuned in 2018 for the release of our book on this very topic. One last note about TLD Group: we have recently been certified as a women's business enterprise. Our WBENC status represents our commitment and our clients' support of diversity and inclusion within the healthcare and consulting industries. Now, before I introduce Dr. Kent Bottles, I'd like to do a quick poll to see the breakdown of the healthcare sectors represented by all of you today. So if you can just indicate which healthcare sector you represent, that would be great. I'm not seeing the poll results. Closed. I think the poll must be closed in order to share the screen.
Yeah, right now we are showing that it's 39% provider and 53% other. So I'm just letting a few more people vote. 87% of people have voted. So just give us a second.
Sure, thanks, Lisa.
Sure. Okay. All right, I've given it a full minute, and it's 38% provider and 53% other.
Terrific. Thank you.
There we go. There are the poll results.
Wonderful. Thank you. Okay, so now onto our featured speaker. Today is with great pleasure that I introduce our timely webinar on the ACA after Repeal and Replace Failed: What Healthcare Organizations Can Expect in the Next Year, presented by our esteemed TLD Group colleague, Dr. Kent Bottles. Dr. Bottles is a TLD Group advisory board member for our APLA program and is instrumental in keeping us informed on key insights, trends, and development needs in the healthcare, insurer, and pharmaceutical marketplace, ensuring that our leadership academies are consistently evolving to meet the ever-changing needs of our clients. Dr. Bottles is also a highly sought-out member of TLD Group's Speakers Bureau, presenting on such topics as clinical integration, physician integration, policy and healthcare reform, physician engagement, and accountability. Our speakers provide keynote addresses, one-day seminars, multi-day board retreats, and conferences for hundreds of executives, helping to strengthen executive leadership behaviors to navigate healthcare reform and drive required change. Dr. Bottles received his BA in History from the University of California, Berkeley, his MD from Case Western Reserve University School of Medicine, and is board certified in anatomic pathology and cytopathology. Before I hand the mic over to Dr. Bottles, I'd like to remind you all to type your questions throughout this presentation, and Tracy Duberman will be facilitating the Q&A portion of today's webinar throughout. So with that, Dr. Bottles.
Thank you for having me here today. It's a real pleasure to talk about what we're going to talk about today. And the agenda is basically, we're going to talk about the Affordable Care Act, then why the Republican effort to repeal and replace Obamacare or the ACA failed. And then now what? In this very chaotic and unusual time, how do we go forward as healthcare leaders? Next slide. So we have to remember that there were problems with the American healthcare before the ACA. Some of those problems included the cost and the contribution to the federal budget deficit. The main reason that the ACA passed and there's a stimulus for having healthcare reform is that one thing Republicans and Democrats agree on is that the American government spends too much money and that healthcare contributes a lot to that. As you know, we now spend about $3 trillion on healthcare every year, which is about $10,000 per person in America, which is twice as much as other countries like Switzerland or Germany or Canada or England, and yet we have much worse quality rankings compared to countries that spend about half what we spend. Before the ACA, there were clearly problems with access, Americans without insurance, rural areas, financial hardships and personal bankruptcies, small area variations of cost and quality, shortages of primary care physicians, mental health providers, and expensive and uncertain individual markets. Next slide. One of the things that's important to recognize is that the passage of the Affordable Care Act has changed public opinion immensely. In 2013, when the Affordable Care Act was just getting started, only 42% of Americans felt that it was responsibility of the federal government to ensure that all Americans have health coverage. Today, that number has risen to 60%. So 60% of Americans believe that it is the responsibility of the federal government to ensure that all Americans have health coverage. Only 39% of Americans believe that it's not the responsibility of the federal government. Next slide. One of the ways to estimate why it's so expensive in American healthcare is to compare consumer prices. If they had grown as fast as healthcare since 1945, a dozen eggs would cost $55, a dozen oranges would cost $134, and a gallon of milk would cost $48. I just went to Costco and bought 2 dozen eggs for $4. So you can see that healthcare prices have far outpaced consumer prices. Next. One of the problems we have in healthcare is that healthcare is different than other industries. Healthcare must do more with fewer workers. In 2012, the US economy produced the same volume of goods and services as in 2007 with 5 million fewer workers. Between 2007 and 2011, the US health system added over 1 million workers despite declining admissions and office visit volumes. Next slide. So the Affordable Care Act was passed about 10 years ago, and we can summarize these 2,700 pages of the Affordable Care Act in 4 words: no outcome, no income. And basically what that means is that the federal government, because it spends too much money on healthcare, is trying to provide accountability for both cost and quality to American providers. And part of that is that we're going to shift from a fee-for-service system to a value-based system. In a fee-for-service system, as you know, every service is provided with a bill. In a value-based payment system, you have prospective payments. So value, as we all know, has an outcome component and a cost component. Value is decreasing per capita cost and increasing quality. Next slide. In this slide, we see what the shift from fee-for-service to value-based care entails. The first curve, labeled number 1, is what most of us are used to. In a fee-for-service system, quality is not particularly rewarded, The more you do, the more you get paid. You pay for volume. Fragmented care occurs. Acute hospitals can stand alone, and standalone private practice physicians do just fine. One of the things that Republicans and Democrats have agreed on is that we need to decrease the amount of money that we spend in the federal government. And one way to do that is to shift from the first curve labeled 1 to the second curve labeled 2. This is the value-based payment curve, where continuity of care is required, systems of care becomes much more important, providers become at risk for payment. It has to be IT-centric. You have to have an electronic medical record to make this work. And physician alignment often means physicians become employed by large systems. Now, one of the problems is that we're in a transition zone, which we call the straddle on this slide. So basically, when you haven't completely shifted from curve 1 to curve 2, from fee-for-service to value-based payments, revenue drops, there's minimum rewards for quality, volume decreases, there's no decisive payment change, pay for volume continues, there's a high cost to get electronic medical record, and physicians don't know what to do. One of the things we'll visit later is it looks like that this straddle is going to continue because some of the decisions the Trump administration is making. Next slide. This three-legged stool, which I borrowed from Charles Zagaba, who's someone that's worth following on Twitter, kind of summarizes what we have in the Affordable Care Act. The blue leg of the stool has guaranteed issue, which means that everyone has to be given health care insurance without regard to their health status. Community rating means that you have to have insurance at the same price in a community without medical underwriting, regardless of the health status of individual patients. The essential health benefits, or the 10 essential health benefits that the federal government put into the ACA, and the minimum AVs are the different metal levels of insurance. The red leg of the stool is the individual mandate. Everyone has to have insurance, or they have to pay a penalty, and then open enrollment periods. Now, the individual mandate didn't work as well as it could have because it was so low that many people just ignored it. The green legs of the stool are advanced premium tax credits to help poor people buy insurance, and cost-sharing reductions. These cost-sharing reductions, or CSRs, we need to sort of stop and talk about just for a second, because we're going to have to revisit it later, because it's a key part of whether or not the Affordable Care Act will continue to be successful under the Trump administration. These cost-sharing reductions, or CSRs, are payments from the federal government to insurance companies to help them defray the cost of taking care of people that have high copays and deductibles. The House sued Obama and said that because of poor language of the ACA, the House had not really authorized these payments. A low federal court agreed with the House, which surprised everybody because usually different parts of government can't sue each other. That low federal district court said that the House was right, but they also said that the government should continue to pay the cost savings reductions until that suit goes through the entire court. So what's happening now is that the Trump administration is paying these payments, which are about $8 billion a year, to insurance companies on a month-by-month basis. They just said they would continue to pay the ones for August. Now, the problem with that is it lends uncertainty to the insurance companies. They don't know whether they can rely on these payments or not. So we'll revisit these cost-sharing reductions later in the talk. But the main part about the three-legged stool of the Affordable Care Act is if you shorten any part of the blue, the red, or the green legs, the stool wobbles. If you remove any section, the stool collapses. This shows that all the parts of the Affordable Care Act are intertwined. And so you really can't get rid of the individual mandate and then try to keep things like allowing people to buy insurance without pre-existing conditions. Next slide. So the important thing to think about is how are Americans currently covered? Americans are currently covered by employer-based insurance. About half of us get our insurance through our employment. Non-group individual market is about 7%. So these are the market exchanges, and this is what everyone talks about when they talk about that the healthcare system is in death spiral. Medicaid now covers over 20% of Americans, and Medicare covers about 14%. When you translate these percentages into actual number of patients that are covered by the different parts of insurance, we see that employer-based insurance covers about 156 million Americans, Medicaid and CHIP, 74 million, Medicare about 55 million, and non-group individual market about 17.5 million. So of the non-group individual market, which is the exchanges, 10.8 million are unaffected because they get federal subsidies. It's only 6.7 million Americans. That's a lot of Americans, but it's not that many compared to other people that have employer-based Medicaid or Medicare. But 6.7 million Americans are affected by these premium increases, increase in deductibles, and unaffordability of healthcare under the Affordable Care Act. So it's important to recognize that when we talk about all the problems with the Affordable Care Act, we're really talking about a small number of people that are affected. So if we look at Obamacare, we can say that there's been some successes and there's been some failures. Successes clearly are that more people are covered by healthcare. Successes also are that more people now have the ability to buy insurance. There's also been some failures of the healthcare insurance problems in America. So if you're grading Obamacare, you really have some successes, some failures, and incompletes about it's unclear if the law has made us healthier, it's unclear about the impact on healthcare spending, and it may have improved the quality of healthcare. One of the problems that's interesting is why the Republicans were so against the Affordable Care Act from the beginning. Ezra Klein has identified what he calls the real versus fake position of the Republicans. And this prominent New York Republican conservative has said, if Republicans cannot defend the idea that what is important is the freedom of the individual to make choices about how to live his life, as opposed to the notion that we are all in this together and must participate in healthcare to balance each other's healthcare outcomes, then we've accepted an essential social democratic principle, and that's a huge concession. What he's saying is that Republicans who are very conservative really don't think that the federal government should be involved in healthcare at all, and that the freedom of the individual to make decisions, perhaps to not be involved in healthcare, is more important than covering Americans. The real versus fake position is that real position is that the federal government should not be involved in healthcare is hard because we just saw that now the public believes that the federal government should provide a safety net for medical care. And so what they have a problem is they have to attack the Affordable Care Act on what Ezra Klein has called a fake position, that it doesn't work or that there's some problems with it, when really they just don't want to provide health care at all. So basically, the Republicans have now taken over the House, the Senate, and the White House. And on May 4th, after one unsuccessful attempt, the House of Representatives passed the AHCA, or American Health Care Act. It eliminates taxes and tax increases in the Affordable Care Act. It phases out funding for the Medicaid expansion. It provides for block grants or per capita Medicaid caps, which would cut the responsibility of the federal government to support Medicaid. And it removes individual employer mandates. Age ratios can go from 3-to-1 to 5-to-1. In the Affordable Care Act, you couldn't charge any more than 3 times as much for older patients than younger patients. And this AHCA went to 5-to-1, and states could waive essential health benefits. It passed on May 4th and also had a penalty for those who do not have continuous coverage, $138 billion for a high-risk pool, and had age-adjusted fixed dollar tax credits, which replaced the ACA means-tested subsidies. The winners and losers of this bill, which just barely passed by 4 votes in the House of Representatives, were clear. Winners were wealthy Americans because there was about $1 trillion in tax cuts, getting rid of the Obamacare taxes and also getting rid of funding for Medicaid. Young people would have lower premiums. Health insurers, medical device companies, and pharmaceutical companies would not have to pay the taxes they've been paying in the past. Losers included Medicaid recipients, state budgets, which would have to make up for the fall in federal funding for Medicaid, or else not give Medicaid to as many people. Older, sicker, poorer patients would pay higher premiums. There was a $9 billion cut in healthcare and hospitals. Next slide. So basically, it passed the House barely. It then went to the Senate, where many of the people that voted for it in the House hoped that the Senate would improve the problems. In the Senate, there was an ad hoc group put together by Senator Mitch McConnell, the majority leader, that included these 13 senators and no women senators. Next slide. The issues in the Senate included Medicaid expansion, which was unpopular because many Republican-controlled states, such as Arizona, Nevada, and Ohio, had expanded Medicaid, and they did not want to eliminate healthcare insurance for all of those people. The opioid abuse crisis, most of the funding for opioid abuse treatment was coming through Medicaid. Pre-existing conditions, people did not want to be denied insurance if they had pre-existing conditions. Senator Collins and Senator Murkowski of Alaska did not want to defund Planned Parenthood. And states that did not expand Medicaid, they wanted to be able to get some credit because they hadn't expanded Medicaid and it supported the GOP. The other problem in the Senate was that they were trying to pass this repeal and replace legislation under reconciliation rules. And reconciliation rules mean that you can pass it with 50 votes, but all of the provisions of the legislation must include direct effect on the budget. Next slide. So the GOP failed 3 times to repeal the Affordable Care Act, ending on July 28th. In a very dramatic week, they first tried the repeal and replace bill that McConnell had put together in secret. It was called the Better Care Reconciliation Act, and it failed 43 to 57, with all Democrats voting against it. The Obamacare Repeal Reconciliation Act, which would have been repeal and delay, was also defeated, 45 to 55, with all Democrats voting against it. And famously, the skinny repeal, or Healthcare Freedom Act, was rejected 49 to 51 when Lisa Murkowski of Alaska, Susan Collins of Maine, and John McCain of Arizona voted no, joining the Democrats to narrowly defeat this attempt to repeal and replace Obamacare. The skinny repeal was basically a attempt to just pass something that would get rid of the individual mandate and the employer mandate, and then try to come up with a better bill in a conference committee with the House. Next slide. So why did the GOP fail in their attempt to repeal and replace Obamacare? The biggest problem was there was no clear replacement plan or goal. And as Craig Fairwatt, who's a conservative healthcare policy analyst at Northwestern, said, one of the problems was that passing an ACA replacement is very difficult because the existing ACA system is fundamentally a collection of moderately conservative policies. What Obama tried to do was take a heritage fund proposal and build on Medicaid, Medicare, and private insurance instead of going for a public option or a single payer option. He hoped that that would get a lot of Republican support, but it didn't. What it turned out the GOP tried to do was repeal all the ACA taxes. There's about $1 trillion in repeal of taxes. Eliminate Medicaid expansion, cap Medicaid spending so that the federal government would have more certainty in its budgets going forward, and shrink the subsidies and roll back insurance regulations. Next slide. Another reason why the GOP failed to repeal the Affordable Care Act is that even though you hear a lot of rhetoric that it's failing, it turns out that it was working fairly well, not perfectly, but fairly well. The Kaiser Family Foundation found that 80% of the individual market enrollees, that's that 7%, rated their Affordable Care Act policy as excellent, very good, or good. Of the 932 counties in the United States, over 3,000 counties in the United States, 932 had 3 or more plans for 2018. And as of today, this slide actually is not quite right. There's only one county that has 0 plans for 2018. So although the Republican mantra was that Obamacare is failing, it must be repealed, the status quo is not good, it really hasn't been failing. And I was interested to hear last night Paul Ryan during a town hall say that the status quo cannot stand because dozens of counties in America have 0 coverage for health insurance on the individual market for 2018. As you can see from this slide and a slide of maps coming up, it's really only one county that has 0 plans, and that's a county in Ohio. The biggest problem perhaps with repealing Obamacare was that taking away benefits is hard after people have received them. The CBO estimated that repeal and replace, that first thing the Senate failed to pass, would have caused 22 million Americans to lose their health care insurance. The CBO says repeal alone would have cost 32 million people their health care insurance, and the skinny repeal would have cost 16 million people. It's hard to take away benefits from people after you've given it to them. Next slide. So is there a death spiral that Paul Ryan and President Trump keep talking about? Actually, if you look at it carefully, Standard & Poor's did a study looking at over 5 million people on Blue Cross plans, and they were seeing the first signs in 2016 that this individual market could be manageable for most health insurers. The market's not in a death spiral. So we're talking about that individual market, which is 7% of how Americans get their health care insurance. Next slide. This study showed that insurers reduce their loss every year. They would break even this year. They could be profitable by 2018. And they did not agree with, they agreed with the CBO analysis and disagreed with Paul Ryan and President Trump. They didn't point out, however, that the market is still very fragile and could be disrupted by lack of Trump administration support. So here's a slide which shows a map of America. And this is when people were really worried about a month or so ago, showing some counties in Washington State, many rural counties in Nevada, a few counties in the Midwest, and some counties in Michigan and Ohio and Tennessee that looked like they would have no insurers for 2018. So, but as of today, this is insurance coverage for 2018. And you can see on this map that the dark green means that they have more than 3 insurance carriers. The lighter green is 3 carriers. The yellow is 1 carrier. And the red, which you can barely see, are counties with no carriers for 2018 in the individual market. If you look carefully, you can see 1 red spot in Michigan and 1 red spot in Ohio at the border with Indiana. It turns out that as of today, next slide, there's only 1 county that's at risk of having no insurance. And that would affect about less than 300 total enrollees. What's happened is that insurance companies have decided that if there's no competition in some of these counties, perhaps they can make a go of it. Governors have talked to insurance companies to try to get them as good citizens to enroll folks. And it does look like that almost all Americans will have insurance company for coverage for 2018 under the Affordable Care Act. So Tom Price, who was a congressman from Georgia and is an orthopedic surgeon, has been appointed by President Trump to be head of HHS, Health and Human Services. And it looks like that Dr. Price has always been a fierce opponent of the Affordable Care Act. And Dr. Price really would like to do things to help doctors. It's interesting that doctors gave over $500,000 to Price's campaign to continue in Congress. And Seema Verma, who is the head of CMS under Trump, has said, we've heard the concerns of many doctors that too many quality programs, technology requirements, and measurements get between the doctor and the patient. That's why we're taking a hard look at reducing burdens. So that's why we said that although there still appears to be the transition from fee-for-service to value-based payments, with Dr. Price heading up HHS and Seema Verma heading up CMS, it looks like that transition from fee-for-service to value-based payments will go much slower than we thought it would under perhaps a Hillary Clinton administration, for example. Again, back to why the GOP failed. Passing a bill in secret does not work well. In both the House and the Senate, they did not use regular order. Regular order means that legislation comes before various committees, experts come and testify, Congress people from both parties are allowed to provide amendments which are voted up or down. In both the House and the Senate, instead, what they tried to do was create bills in secret and then have them passed, in some cases, even without a Congressional Budget Office score. Many GOP senators did not defend the secret and rushed process that Senator Mitch McConnell put in place. There really wasn't a lot of time for debate, and clearly much less time for debate than there had been for the Affordable Care Act. In the very dramatic last week, when the Senate turned down the repeal and replace, you had this very strange press conference where Senators Cassidy, McCain, Graham, and another senator came and said, we're probably going to vote to repeal Obamacare, but we really don't want it to become law, what we're voting on. And Senator Graham actually voted for a bill that he described as, quote, terrible policy and horrible politics, a disaster and a fraud. So you basically had a very rushed attempt by the GOP to repeal and replace Obamacare without the usual regular order allowing people to debate it and show what was good and what was bad about it. Another factor involved in the inability of the Republican Congress to repeal and replace Obamacare was that when you have a really tough vote that may come back to haunt a senator or a congressman, presidential leadership can be crucial for getting the last few people to vote for an unpopular measure. The problem here was that by polling, the president is relatively unpopular. The president did not know the details of any of these proposals and so could not convince congressmen and senators to support them. After the president had said that the House bill, the AHCA, was a great bill and it had a celebration in the Rose Garden to celebrate its passing, when he was talking to the Senate, he called the House version mean. So suddenly people that were taking tough votes in the Congress were worried whether the president would turn on them if it wasn't popular. The president's criticism of Attorney General Sessions and more recently the president's criticism of Mitch McConnell have really created a gulf between the Senate especially and the White House. Senators increasingly are not afraid of the president of the United States, and that makes it hard for the president to cajole Republicans to vote for unpopular bills. Another reason why it was difficult to repeal and replace Obamacare was Republican governors. Republican governors, especially in Arizona, Nevada, and famously John Kasich of Ohio, were really against these bills because they would really undermine the coverage that they've given to poor people in their states through the expansion of Medicaid. Ohio, Arizona, Nevada, and other Republican states such as Arkansas had expanded Medicaid and were worried that suddenly many of their constituents would be thrown off of their health care insurance. As we saw in the beginning of the talk, it looks like now 60% of Americans want their government to provide a safety net for medical problems. And another factor in the defeat of the repeal and replace of Obamacare was that several former Obama officials created Protect Our Care, which organized support for the Affordable Care Act. Andy Slavitt, who ran CMS under Obama at the end of his administration, was particularly active on Twitter, even going to different parts of the country and holding town hall meetings when Republican congressmen refused to. So quickly, there was organized support for the Affordable Care Act. Next slide. Another reason why the GOP failed was that the GOP clearly cares more about tax reform than health, and the health care is not a key GOP issue. Lack of staff with legislative experience and their small government dogma made it difficult for them to be able to come up with compromises that could pass. One of the things that you hear from Republicans is that healthcare should just be allowed to work in a free market. When economists look at healthcare, they say that that doesn't always work because there are externalities which complicate buyers and sellers. Externalities are things like when buyers and sellers can just make a market by agreeing on a price and buying something from each other. That's unusual when you have things like vaccines and research, which have positive spillovers that don't really affect the people that are making the market. Consumers don't know what they need. Healthcare is unexpected and expensive. Insured consumers overconsume, and insurance markets have adverse selection. Next slide. Another problem with repealing Obamacare and cutting back on Medicaid expansion was that this Kaiser Family Foundation survey found that Medicaid seemed to be working about as well for taking children for a checkup, seeing doctors, seeing specialists, and being satisfied as private insurance. Next slide. Most Americans didn't realize how much Medicaid and CHIP cover 20% of Americans now, including 3 in 5 nursing home residents, 2 in 5 people with disabilities, 2 in 5 children, 1 in 2 low-income individuals. So, next slide. When the public heard about these bills in Congress to repeal and replace Obamacare, they felt that they couldn't support the legislation. 64% thought the failure at first of the House bill was a good thing. 3/4 wanted Trump to make the ACA work, and 60% said he would hold Trump and the GOP accountable for problems with the ACA going forward. And famously, only 17% of Americans, according to a Quinnipiac poll, favored repeal and replace Obamacare the way that the Senate and House were attempting to do it. As we've seen now, here's another poll showing that 70% support requiring states to protect people with pre-existing conditions, and 60% want the government to require coverage for things like maternity care and mental health services. Another problem for repealing and replacing Obamacare was that over 50 societies, almost all societies that represent doctors, hospitals, patient advocacy groups, were opposed to the legislation. And you can see a list of many of those organizations here. Next slide. So let's pause there and see if there's any questions.
Hi, Kent, it's Tracy. We do have a few questions. So the first question was regarding one of the slides early on when you were talking about those the ways in which individuals are covered. When you looked at the different ways, it added up to 90% on that slide. Does that indicate that 10% are uncovered in full? They fall between the gaps?
There still are many people that don't have health care insurance, even though the Affordable Care Act has given insurance to over 20 million people. We still have some folks that, for whatever reason, are not covered. So, and again, those two slides actually come from different studies, so the percentages may not add up perfectly.
Okay, great. And then the other question was both a statement and a question, so I'll read it in full. It says that it's sad that the American people can't get a straight answer from our legislative representatives or the president on health care. Paul Ryan talked about one of the pieces of the new plan, which was for people to be covered by a catastrophic plan, and then the insurance companies would provide general coverage, taking the risk away from the insurance companies and putting it on the government. This individual did not read either versions of the healthcare bill, but is wondering whether or not that's true or political rhetoric.
Again, I think it goes back to that slide that we talked about, that you can have a conservative approach where you don't believe that the federal government should provide health care to everybody. That basically that's the small government approach. What they've said was that because they're opposed to the Affordable Care Act, and many of these proposals, and again, the Senate voted down 3 different bills, the House finally voted 1 bill, but when you look at those bills, one of the things that they try to talk about as a way to say, well, we want to cover everybody, but again, going back to that 3-legged stool of the Affordable Care Act, it's really hard to cover everybody and take away the parts of the Affordable Care Act that you don't like. So one of the things that Republicans have proposed are what's something called high-risk pools. And what this would do is to try to decrease premiums and deductibles for most people. What they would do then is kind of segregate And instead of having community rating where everybody's in one big pile, they would then have a pile of relatively healthy people that would have relatively cheap insurance, and then a pile of really, really sick people with multiple conditions, a high risk pool. And that would then be able to allow people that were in the low risk pool to have good insurance that was relatively cheap. The problem with high risk pools is they've been tried in the past and they haven't worked out very well. Washington State, for example, a while ago elected a bunch of Democrats, and they went to this exact kind of almost an ACA kind of proposal. And then as a backlash, a couple years later, the Republicans took over the House and put in a high risk pool. And what happened was that the high risk pool, they never fund them with enough money, so that all these sick people then don't have the coverage that they're supposed to have, and premiums go up so high in the individual market that nobody sells insurance. So the Washington State experience was the high risk pool wasn't funded enough, and that for several years no one could buy individual market insurance. This is a really, really important point. When we talk about the death spiral, and Paul Ryan talked about it yesterday at the town hall meeting I watched on TV, what they're talking about is that 7% of the individual marketplace, they're not talking about Medicaid or Medicare or people that get their insurance from private, from their employer. And again, as we said, only about 6 million of those people under the 17 million in the individual markets have had the problem of really, really high premiums. It goes back to a basic fundamental kind of precept of healthcare insurance, that healthcare insurance works best when you have as large a pool as possible of lots of healthy people and lots of sick people, because we really don't know who's going to get sick in the future. And so the individual mandate was supposed to say, if we can have everybody have healthcare insurance, then when someone gets really, really sick, we'll have enough money in the system to be able to take care of those folks without having excessively high premiums. And so that's how healthcare insurance works. But again, if you're a fundamental conservative, and there's nothing wrong with that, you don't believe that you should have this, as that quote said, that you really shouldn't have you should have the freedom to say, I don't want to be part of the system. But if you go back to that three-legged stool, if you take out any parts of those stools, the legs of the stools, it wobbles. And so that's one of the problems, is that people don't like the unpopular parts of the ACA, which are the individual mandate, the employer mandate, and the taxes. But those unpopular parts of the ACA pay for the things that people like you're able to get insurance even if you have a pre-existing condition. If you get really, really sick, it won't bankrupt you. So one of the problems that we have is a fundamental difference of opinion about whether healthcare is a right or a privilege.
Great. Thank you so much. And two additional questions very quickly.
Oh, great.
Okay, super. Do we expect the move to block grants as a way to halt the growth of Medicaid to succeed? And if it does, how will this impact Medicaid providers like Centene, Molina, and others? Will they get more or less business through capitated contracting, or will they step aside and let states run their own programs with declining funding?
It's clear that the whole issue of what they wanted to do with Medicaid, if you think about it, it's interesting. Why they could have repealed and replaced Obamacare and not touched Medicaid at all, except for the expansion. Instead, a long-time goal of the Republicans has been, we've got to stop the open-ended funding of Medicaid and Medicare. And what if you do block grants or per capita block grants, and there's sort of two different ways, but basically saying that the federal government would know exactly how much money it was going to spend on Medicaid every year. The problem is that states that it doesn't look like that the initial money going to the states would be the same as it is now. Another problem would be that their ability to adjust that for inflation would probably look like that there would be state underfunding for Medicaid. And so the state governors like Kasich, who's a conservative Republican in Ohio, was saying, you can't do this to us because it would wreck our state budgets. If you think about it, Medicaid, if you have a block grant from the federal government that goes to the state, and no more money comes. What do you do if there's an Ebola virus outbreak or a Zika virus outbreak or some terrible healthcare problem that we hadn't anticipated? So that was why the governors from Arizona, Nevada, and Ohio and Arkansas, even though they're Republicans, were not real supportive of this block granting back to the states. Now, that's been a long-term goal of Republicans, so that basically if there's not enough funds at the state level, they would either have to raise taxes in the states to cover the people or decrease the amount of benefits under the Medicaid program. And I think in the last half of the talk, we're going to talk a little bit about waivers, which can be used to customize Medicaid for the states. And that's something Seema Verma, who's the new head of CMS, is very famous for, and she's a real expert in Medicaid. So we'll probably address that in the second half of the talk, that the Price and Seema Verma want to allow states to have more flexibility. But it looks like that the problem of the Republican approach to cutting Medicaid in both the House bill and the Senate bill was that Medicaid now touches about 20% of all Americans and covers 74 million Americans, and also covers CHIP, the Children's Health Insurance Program. And so that's a huge, again, it's hard to take benefits away from people once you've given it to them, because people in general want health care insurance.
Excellent, excellent. And then we have one additional question before we get into the tail end of the presentation, which is, do we have data yet to support whether or not the ACA had an impact on value? In other words, either decreasing the cost and increasing the health outcomes, or some combination of an iteration of that to increase value?
We don't have really great data. There's a fairly good article of which Atal Gawande is one of the authors in a recent edition of the New England Journal of Medicine, which does a nice job of trying to summarize all of the data about whether or not the ACA has actually improved health. And it's hard to show. There's some studies out of Oregon. Oregon had kind of a natural experiment where they had a lottery for Medicaid expansion. And so you could compare those that got Medicaid expansion to those in Oregon that didn't. It was hard to show that they had really increased health status. What it did show was it improved the financial outcomes of those patients, that they had fewer people going to collections and things like that. But there's a nice review article in the New England Journal of Medicine the last few weeks, and Atal Gawande is a middle author in that shows all of the studies that it's really too soon to know. But it looks like that we're starting to see that the ACA has improved health. But that's why I gave it an incomplete when we went through the report card of the Affordable Care Act, because we really don't know. One of the problems of studying this is we don't know how much is the effect of the ACA, and what happened with the 2008 recession. A lot of people just didn't have money and didn't get health care. So it's been a little bit difficult to study it. It looks like there's beginning to be some evidence that the ACA is improving health, but we really can't say that with peer-reviewed certainty yet.
Okay, super. We'll let you continue along on the presentation for now.
So the slide that I'm on says, so what happens next? And anyone who's been trying to predict what happens during this recent political environment should be cautious because it's very difficult. It looked like that the AHCA in the House went down in defeat. It then came back and was passed narrowly when they did some changes around the edges. Near as I can tell, the ACA will remain the law of the land. We're on recess right now from Congress. They're coming back in September, but they really only have about 10 to 12 legislative days, and that's when the legislature is in session in both the House and the Senate. And here's the problem. They really wanted to get the ACA repeal and replace done a long time ago. And that's because there's a few things they have to do before the end of the year. They have to raise the debt ceiling. And that's because raising the debt ceiling pays for all of the federal bills that we've already spent. If we don't raise the debt ceiling, which actually can be controversial and has caused shutdowns in the past, if we don't raise the debt ceiling, then the federal government is reneging on some of the things it's already bought. So that's got to be done one way or another. They also have to pass a budget. And the Trump administration has presented a budget that was rather controversial that even many Republicans have rejected. They, as we said, healthcare is not their favorite issue in terms of Republican policymaking, and they really would like to get a tax reform or a tax decrease. Now, the failure of repealing the Obamacare, if you remember, there's about $1 trillion in tax cuts, mostly for the wealthy, in the bills the bill that passed the House and the bills that did not pass the Senate. So by not passing the Affordable Care Act repeal, it makes it much more difficult to do tax reform. And that's something they really, really, really want to do. If you watched the town hall meeting with Paul Ryan last night, he was saying he thinks it's going to be much easier. Some people are not so sure. They also would like to pass an infrastructure bill, which would provide a stimulus to the economy, rebuild roads and bridges and things like that, and might be able to get some bipartisan support. They also, before the end of the year, have to pass a defense bill, and CHIP, the Children's Health Insurance Program, has to be renewed by the end of September, or else many children will be thrown off of their health care insurance. The reason I bring up all these other issues is it doesn't look like they're going to have time to deal with the debt ceiling, the budget, and all these other issues, and go back to square one and try to repeal and replace Obamacare. There still is one attempt out there. It's the Cassidy-Graham-Hiller bill. Cassidy is the hepatologist senator from Louisiana. This one has not been scored by the CBO, but they're still working on it. It would eliminate premium tax credits and the cost-sharing reductions of the ACA, and it would be a block grant to states and Medicaid. The problem is that as I look at it, and as other experts far better than I am look at it, it looks like that one would deny insurance to millions of people as well. So most people think that Senator McConnell has suffered a very bad political defeat by not getting this through the Senate, and that he's not going to be able to bring it up until the end of this session, which ends in December. So it looks like the ACA remains the law of the land. That's my prediction. I could be surprised, and maybe they will repeal Obamacare. I don't think they can, mostly because of the logjam of other things they need to do. And the other thing is that if you're a student of politics, it turns out that the closer you get to the 2018 elections, the harder it is to pass anything, because people don't want to make a vote that's going to be difficult for them in their re-election campaign. So most people say you've got to get stuff done in your first year. So far, there has not been a lot of legislative achievements, and that's why both the Republicans in the Congress and in the White House are very nervous about their inability to pass anything. So what happens next? The Trump administration must implement and manage the Affordable Care Act. It's the law of the land until it gets overturned, if it ever gets overturned. Now, I've watched Tom Price, the orthopedic surgeon from Georgia, who is the secretary of HHS, on many of the Sunday shows, and he always says, I will support and uphold the law of the Affordable Care Act. And then he spends another paragraph telling all the things that are wrong with it. He clearly has always been against the Affordable Care Act, but he's now the person in charge of implementing and managing it. So some people are worried that there's evidence both of them supporting it and implementing it, but other evidence that they're undermining the Affordable Care Act, and we'll go into that in a few more slides. The biggest what happens next is, how do we as healthcare organizations, how do we as healthcare leaders respond to the mixed messages that are coming out of the Trump administration and out of the Congress? Next slide. So we said that Tom Price, who's an orthopedic surgeon, is now the Secretary of Health and Human Services. He's also a dues-paying longtime member of the Association of American Physicians and Surgeons and has received many awards from that organization. That organization is not mainstream, in my opinion. Their statement of principle says it's evil and immoral to participate in Medicare and Medicaid, the programs of which Tom Price is in charge of now. And that society clearly has an Ayn Rand political philosophy. Next slide, they've even talked about electronic medical records as being like data control. They've had some anti-vaccination positions. Interestingly enough, they have been against getting rid of fee-for-service. And as we said, that's one of the few things that Republicans and Democrats have agreed on, is that in order to decrease the federal budget deficit, we really need to go from fee-for-service to value-based payments. They've also had some criticisms of evidence-based medicine, and clearly Tom Price is very much in favor of extreme physician autonomy. They're against bundled payment reform. And just last week, Tom Price and HHS proposed that all of those bundled payments programs from CMS that were a hallmark of this value-based payment transition were going to be slowed down or stopped. The original plan was that these bundled payments, I think they're for heart attacks, for bypass surgery, for hip surgery and knee surgery, were going to become involuntary. You had to do them. Tom Price is proposing that we really slow down that bundled payment reform. And as we'll see toward the end of the talk, I really think that's going to make that straddle between curve 1, fee-for-service, and curve 2, value-based payments. It's going to make that straddle extended. And so we're going to have more confusion and chaos for the foreseeable future. Next slide. The person running CMS now is Seema Verma. She used to be at the Association of State and Territorial Health Officials. She has an MPH from the well-regarded Johns Hopkins program. She founded a consulting firm that was very successful. It was successful because they became experts in 1115 Medicaid waivers. She was the one who, when the vice president was governor of Indiana, put together a successful waiver proposal to HHS for Indiana to expand Medicaid. She's also worked on Medicaid waivers for Ohio, Kentucky, Tennessee, Iowa, and Michigan. And she's married to a physician, a child psychiatrist. Now, Andy Slavitt and Don Berwick, who ran CMS under Obama, have written op-ed editorials in USA Today and in the New York Times, really claiming that the GOP under Trump is undermining the Affordable Care Act. They point to the problems of the refusal to negotiate and improve the Affordable Care Act, the lawsuits. And so we've already sort of talked about, when we talked about the three-legged stool, we talked a little bit about these cost sharing reductions. So these cost sharing reduction subsidies are in the law. They were challenged by the House of Representatives. They're now in the federal courts. And Trump has publicly said, I think I'm going to end those because that would crash Obamacare. He said that to the Wall Street Journal. That's part of why the insurance companies feel such uncertainty and why some of them are saying we've got to raise our premiums a lot. Marco Rubio in 2015 cut off some of the risk corridor funds under the ACA to compensate insurers with excessive losses due to sick and elderly patients. And he bragged about that when he ran for president. So they also point out on the next slide that they can cut budgets to needed data systems. They can stop outreach programs, and they've called outreach programs to get people to sign up for the ACA as propaganda. In January of 2017, the new administration stopped ads they'd already paid for to try to get young people to enroll for 2017. CMS waivers are going to really be popular because Seema Verma likes them and knows them, and for states to avoid parts of the ACA regulation. And Tom Price has publicly said that he does not support the Center for Medicare and Medicaid Innovation, which has put out billions of dollars of grants for state pilot projects. So these two Obama CMS leaders are worried that the Trump administration is already undermining the Affordable Care Act. Trump himself has been all over the map on this. He said that he's going to have health care insurance that is cheaper and better and will cover more people. It's pretty clear that he has not educated himself about the nuances of health care. He said that the Affordable Care Act or Obamacare is imploding and soon will explode, and it's not going to be pretty. He told the Wall Street Journal that these cost-sharing reduction subsidies, these $8 billion of payments from the federal government to insurance companies to help with poor people's premiums and deductibles, that he would just get rid of those to negotiate the repeal of the ACA. And he said, Obamacare is dead next month if it doesn't get that money. They just last week said they would pay the August payments of these cost-sharing reduction subsidies, but they have not committed to paying the next month. So it's on a month-to-month basis, which causes the insurance companies to say, that's very uncertain. We don't know whether we can count on this $8 billion that we're counting on to help subsidize insurance for people that are less wealthy. Just last week, the Congressional Budget Office, in response to some Democratic requests, talked about if you got rid of these CSRs, these cost-sharing reductions, what would happen? The Congressional Budget Office said that premiums would increase for the individual market, again, just that 7%, by 20% in 2018, and premiums would increase by 25% in 2020. Maybe more worrisome, it actually would increase if you got rid of these subsidies, these $8 billion in subsidies, it actually would increase the federal budget deficit by $194 billion over 10 years. So again, the whole reason we're trying to do healthcare reform is to decrease the federal budget deficit. If you got rid of the subsidies, you actually would increase the federal budget deficit, which is a problem. Doctors, hospitals, insurers, consumer groups, and the U.S. Chamber of Commerce all are saying, gosh, you got to keep these cost-sharing reductions in place, or else you'll have chaos in the individual market. Next slide. So because of all this uncertainty, healthcare insurers are wary of participating in 2018. Famously, United Health Group has pulled out of most of their coverage. Aetna has pulled out of many areas. Anthem has said they're leaning toward exit. WellPoint Blue Cross in Iowa pulled out of everything, and now there's only one insurer left in Iowa. And when you ask them, they say, gosh, we need bigger rate increases, or we need to withdraw because we just don't know how to price our product. If there's so much uncertainty about cost sharing reductions, if there's so much uncertainty about whether the law will be repealed, we don't know what to do. And there's some quotes from insurers, there's no way on earth we can accurately price right now. We haven't made any decisions in terms of our participation. They have to make their decisions by the end of August, total decisions by the middle of September. And the Molina folks have said, you get to the point where you say, if we don't have the information, we can't go forward. Next slide. In a nice article by the New York Times, and the New York Times and the Wall Street Journal have done a nice job of really getting into the weeds of this. They wrote after the election in the New York Times an interesting article about how to fix or wreck the Affordable Care Act. They said one way you could wreck it would be to cut off the cost-sharing subsidies we've just talked about. One way to fix it, continue those and let people know you're going to continue them. One way to wreck the Affordable Care Act is to defang the individual mandate. The individual mandate is enforced through the IRS, and there's been some issues that the IRS is now saying, we're not going to charge the penalty if you don't have health care insurance. That worries insurance companies because, again, if young people who are healthy don't have to have health insurance, then you have a much more sick pool of people, and it costs more money to take care of them. So if you defang the individual mandate, you wreck the ACA. If you continue to enforce individual mandate or even make it tougher, you could fix the ACA. You need to keep the websites and outreach running smoothly to keep the ACA working. You need to take actions to decrease gaming of the systems. If you cut off funds, as Slavitt and Berwick pointed out, for computers and for outreach, then that would be a problem. And the other thing is, as you remember, in the ACA, one of the legs of the stool was that there is this essential health benefits. There's 10 essential health benefits that the Affordable Care Act requires all insurance to have. Now, what actually is involved in that is defined by the Secretary of Health and Human Services. So Tom Price can use his discretion in defining these essential health benefits and cut them back without Congress doing much of anything. Just a couple weeks ago, because of all this talk of now we should fix the ACA, a bipartisan group got together and said, here's how you should fix it, and it's very similar to the New York Times approach. Gail Walensky ran CMS under Bush and is a Republican. Lanny Cheen was an advisor to Romney as part of the Hoover Institute and is a very conservative healthcare policy expert. And Ron Pollack is a liberal who supports the ACA. So these folks came together and said, in order to fix it and keep it going and not have chaos in the individual markets, we should encourage all to sign up for coverage. That means not cutting outreach programs. That means enforcing the individual mandate. We should allow more state experimentation. We should ensure funding for CHIP. And again, as I'll remind you, that funding expires in September this year. And if nothing gets put through Congress by September 30th, then the CHIP coverage will go away because it won't be funded. The Republicans on the part of this bipartisan fix would like to have expansion of health savings accounts. But they clearly, these bipartisan folks from the left and the right, said you really got to fund these cost sharing reduction subsidies. That's that $8 billion I keep talking about. That's for copays and deductibles for low income Americans. That's the subsidy that Trump has been threatening to cut off. That's the subsidy that the Trump administration has been paying month to month, which adds uncertainty to the healthcare insurers about whether they want to participate for 2018. Now, we already see changes happening because of the person running CMS. Seema Verma likes to customize Medicaid. So Maine, Indiana, Kentucky, Arkansas, and Wisconsin have all applied for waivers to require work for Medicaid recipients. Now, people that are most people who are Medicaid mavens don't like work requirements because they believe that many people who are Medicaid already work and it discourages people from signing up. But a conservative approach would be, if you're going to get Medicaid, you should be working. So HHS has sent out a letter to all the states saying, hey, we'll approve waivers that are, quote, built on the human dignity that comes with training, employment, and independence. So you're going to see these applications approved because Seema Verma is one of the intellectual giants behind this whole approach. On the other hand, there now are efforts to stabilize the individual market. Lamar Alexander, the Republican from Tennessee, and Patty Murray, the Democrat from Washington State, have said they're going to hold hearings as soon as Congress comes back in session in September. The problem is that it may be too late. Even if Lamar Alexander and Patty Murray came up with a wonderful bill that passed the Senate, was able to pass the House, get signed by President Trump, it's hard to see how that happens with all those debt ceilings and budget negotiations and other things they have to do like tax reform. And Peter Lee, who runs the California marketplace, has said by the end of August, we need to lock down our rates. So it's hard to see how this effort, although it would be great, this bipartisan effort would help. And insurance plans really have to finalize their premiums by mid-August and make final decisions by September 27th. And here it says there's only 10 legislative days when both the House and the Senate are in session before the September deadline. So we worry about this getting done. We worry about CHIP being reauthorized. However, the Trump administration under HHS is doing some things which is positive to supporting the ACA. Alaska, which has done some really interesting customization work, has been approved for a $323 million grant over 5 years for stabilization fund to keep the loan insured to remain and to hold down premiums through the ACA waiver program. So again, the Trump administration can change the implementation of the ACA at the state level by giving waivers. And Oklahoma, Oregon, Minnesota, and Iowa are already applying for similar programs. And New Hampshire and Maine are thinking about applying for such a waiver. So then we get to this point, okay, when Marco Rubio put the rider on the spending bill, he said, why should we subsidize private insurance companies? These cost sharing reductions are just bailouts. And he was able to cut some of them. Well, Susan Collins, the Republican senator from Maine who voted against the repeal, has said, when I hear them described as insurance company bailouts, that's just not an accurate description. The Kaiser Family Foundation has said the insurance companies now by law are required to lower the deductibles under the ACA, and it says they would receive reimbursements for those costs. So these folks are saying they're not really bailouts. Next slide. We said Senator Rubio slipped the rider into the spending bill, calling them bailouts. Interestingly enough, it may be that the judiciary system, again, we have a complicated system of government, will solve the question for us. A federal judge has already made the federal government pay an Oregon health insurer $214 million under this law. And just in the last couple of weeks, Molina Healthcare got $52 million in a judgment. So the insurance companies are suing the federal government in court saying, wait a minute, this is a contract law issue. And there's 26 pending lawsuits by insurance companies saying, you said we had to decrease the copays. You said you would give us these subsidies. You have to pay up. So if all of these lawsuits go the way the first two have gone, then the CSR bailouts would be implemented because of contract law. So that's interesting. Next slide. So we're just now starting to say, oh, enrollment for 2018 under the Affordable Care Act will be under Trump care, will be under the Republican administration because they failed to repeal and replace Obamacare, even though they had voted over 60 times over the last 8 years to repeal and replace it. Well, again, it looks like they're sending out some mixed messages. We said they were supportive of the ACA in approving that Alaska waiver and giving them some money to stabilize their individual insurance market. However, just recently, the Trump administration canceled contracts with 2 companies that helped ACA enrollment in 18 cities. This $22 million was used for enrollment fairs. That contract has been canceled. And we've already mentioned that in January of 2017, HHS halted advertising they'd already paid for. The insurance companies are complaining that there's a lot of internal dissonance in an information vacuum. They can't get a straight answer out of HHS. Why? Probably because HHS was anticipating that the Senate and Congress would overturn the ACA. But now they have to tell us how open enrollment's going to be. We now know that they've cut open enrollment to 45 days from 90 days. So again, the HHS administration has considerable latitude in how they manage enrollment for 2018 under what's now being called Trump care or Obamacare. And we said Trump has threatened publicly to end these CSRs, which would be a problem for healthcare insurance premiums going forward. So just recently, the Kaiser Family Foundation has said in most of the country, the market would be stable, the individual insurance market, the exchanges, the 7% of how we get healthcare in America, if not for the significant uncertainty about what Trump will do. And so if there are no cost sharing reductions, no CSR payments, then the insurance companies are saying, we got to raise premiums 13 to 20%. If you ignore the individual mandate, then we got to raise insurance premiums 2.5 to 23%. If you don't get rid of the healthcare insurance tax, we got to raise premiums 3%. So you can see the insurers are saying, we need certainty in order to price our product, in order to know whether or not we can make money on this market. Anthem has recently published a statement, planning and pricing for ACA compliant health plans has become increasingly difficult due to a shrinking and deteriorating individual market, as well as continual changes and uncertainty in federal operations, rules, and guidance, including cost-sharing reduction subsidies. We'll go back now to an interesting, Richard Hanna recently retired from the GOP. And again, I'm going back to that slide where we said that the Republicans they really believe, many of them, that the federal government should not be involved in healthcare at all. And yet, people have gotten insurance through the Affordable Care Act, and most people want to have healthcare insurance because of all the things that it does for you. What this guy was able to say, I think, the truth, because he was retiring from Congress, again, a Republican congressman, the ACA will in some form survive, and the millions of people who are on it will have insurance. Politically, it's untenable to just wipe it away. At the end of the day, we will have some sort of national health care that's going to look very similar to what we have now. So all of this, in a way, charade of spending 8 years saying we're going to repeal and replace Obamacare has been a problem, because when the CBO comes out and says, your plan will knock 20 million or 22 million or 16 million people off of health insurance that they already have, that is not tenable. It's just, as this person was saying, you can't do it politically. One of the ironies of all of this is that as I talk to healthcare policy experts, many people think that we're closer to a single payer system now than we've ever been. That repeal or discussion of repeal of the ACA may pave the way for a single payer. Most people don't realize that already a third of Americans are covered by Medicare, Medicaid, the military, or the VA. And Mark Bertolini, who's the Republican CEO of Aetna, no fan of the ACA, who's pulled out Aetna from most of the individual markets, in a town hall meeting within Aetna, said that maybe it's time to debate this issue, the single payer system, for the first time. And he pointed to Germany, where the government contracts with lots of private insurers to provide a standardized set of benefits. So it's kind of an irony that the Affordable Care Act looks like it might, and again, I'm not predicting it's going to pass anytime soon, but it might lead to a single payer system. And interestingly enough, a Chicago Medical Society survey has said 67% of Chicago physicians are generally favorable of a single payer system. And Merritt Hawkins just did a survey that just came out about a week ago, saying 42% strongly support single payer among American physicians, and 14% somewhat support. That's 56% of US physicians either somewhat or strongly supporting a single payer system. That's a change. That's a change in what we've seen in the past. Next slide. Again, we've seen this slide before, but it's worth reiterating. This shift in public opinion, I think, is really interesting. 2013, only 42% of Americans, the red bar, thought it was the responsibility of the federal government to ensure that all Americans have health insurance. In 2017, that number was up to 60%. I think this explains a lot of why the Republicans were unable to repeal the Affordable Care Act, which provided health care insurance for about 22 more million Americans. It hasn't covered everybody. It's had some real problems, but you can see that going forward in 2018, there's only one county as of today that will not have an ACA insurer, and that county is in Ohio. Next slide. So this is the slide we started with, the shift from fee-for-service to value-based care. The first curve, the fee-for-service world, to the second curve, the value-based payment world. And what it looks like to me is that we're not going to deviate from this transition. But what's going to happen is that straddle, where we're stuck in the middle, where part of our payers are on fee-for-service, part of our payers are on value-based payments, is going to widen and going to take longer. Why? Because CMS and HHS under Price and Seema Verma really are not in favor of doing this transition. However, if you look at the intellectuals on the left and on the right, they agree. That Gail Walensky, who we said ran CMS under Bush, and if you look at Don Berwick, in a couple of articles in the New England Journal of Medicine, both the intellectuals in healthcare insurance on the right and the left have said we've got to move from the first curve fee-for-service to the second curve value-based payments. And recognize that we're already doing that in some parts of the country. I was in Minneapolis recently, and most of the private insurers there are offering many more second curve value-based payments. So I think that this trend from the fee-for-service to value-based payments is going to continue. I think it may well get slowed down a little bit, but remember how big a difference this is. And you all know this, but under fee-for-service, if you run a hospital, you want your hospital totally filled, every bed filled. You want to be doing as many surgeries and CT scans and lab tests as possible, because every time you do a service like that, you generate a bill and get money. When you go to the second curve, which we're already on the way to going toward, you want your hospital empty. Why? Because you've gotten a prospective payment to take care of a geographic population of people, and every time you have a surgery, every time you have an ER visit, every time you order a CT scan, that's money out of the pocket of the accountable care organization, the organization of doctors and hospitals that's going to provide the care. So the big difference is in the first curve fee-for-service, you want to increase volume, and your second curve value-based payments, you want to decrease the volume of the services that you provide. It's a huge cultural change, and it's one that many of us, especially physicians, have a hard time getting our head around. Next slide. Well, where are we? This is the Kaiser Family Foundation does almost weekly polling, and this is from August. So this is up to date, kind of after the failure of the Senate and the House to repeal and replace the Affordable Care Act. This is what the American public wants. In total, 78% want the Trump administration to do what they can to make the Affordable Care Act work. Only 17%, that's that top total bar in the orange, says you should do what you can to make the law fail so you can replace it later. That 17% is a number that keeps coming up in different polling, that only 17% of Americans think that we should repeal and replace Obamacare immediately. If you look by political party, obviously 95% of Democrats want the Trump administration to make the law work. Only 4% want it to fail. But even among Republicans, 52% of Republicans want the Affordable Care Act to work, and 39% want it to fail. And even Trump supporters, 51% of Trump supporters do not want the Trump administration to make the Affordable Care Act fail. So it looks to me like that the Affordable Care Act will barely survive. It will be implemented in a haphazard way that in some ways will undermine it, in some ways will support it, and that we're sort of, fasten your seatbelts. I think we're in for some very turbulent times in healthcare. So the last slide is sort of take-home messages. My prediction, which I am scared to give, but I think it will continue to be the law of the land, the ACA. I think implementation will be uncertain and chaotic. I think organizations should continue to prepare for value-based payment programs, but recognize that the transition may slow down. I think organizations will need to provide excellent care for much less reimbursement. I don't think that we can continue to add 1 million employees and have revenues fall. And I think that Americans now expect and will hold the federal government accountable to provide a medical safety net. So I know that this has been kind of a wild, quick, stomp through a very complicated issue. But I do think that it's a nice time with Congress in recess for us to take, to sort of try to figure out what's going on, and more as we can tell, say what's going to happen next. And I think we have time for as many questions as you have.
Thank you, Kent, very much. First and foremost, we've gotten a lot of comments indicating that this is a very value-oriented webinar on a very confusing and complex, uncertain topic. So thank you very much for your insights and intellect around this issue. I've got 3 or 4 questions based upon similar statements that were made throughout the webinar. The first is around Tom Price's view and the changes to the implementation of VBR. What do you believe will be the impact on MIPS and MACRA? The concern here is that most physicians are risk adverse, and their acquisition of technologies to support VBR will slow down given the uncertainty in Washington.
It's a great question. And first, you can say Tom Price voted for the MACRA legislation as a congressman from Georgia. He has gone on record saying that he likes fee-for-service a lot better than value-based payments. So I think that you might see some adjustments to MACRA, and we're already seeing some in the proposed rules. However, MACRA is a totally separate law from the Affordable Care Act, although it's intertwined with it. So even if they had repealed the Affordable Care Act, MACRA would still be the law of the land. And nobody I've talked to thinks that they're going to totally get rid of MACRA. Why? Because they don't really want to revisit the SGR fix. As you remember, the SGR fix was that from 1998 till 2015, every year there was a proposed about 20 to 30% decrease in CMS funding for Medicare for doctors. It was part of a big omnibus budget bill that was passed under President Clinton. Every year Congress chickened out and didn't do the cut to physician payments, and so the SGR fix under MACRA took care of it. However, it also totally changed the way we're going to pay doctors and created this MIPS and alternative payment models. The MIPS, as you know, is the report card where every doctor will get a report card from 0 to 100 based on their value in a way, their cost, per capita cost, and their quality. So I think that we're still going to have to implement MACRA. It's worthy of noting that some of the rules that are being put in place, that remember that 2017 was the first year for MIPS and MACRA, and they weren't going to use cost as part of your report card. they've actually extended that. So 2018, the cost of the care you give will not be part of your MIPS report card 0 to 100 score. So they're slowing things down. So that's another data point to say that the fee-for-service, the value-based payment's not going to go away, but the implementation will probably be slowed down under Dr. Price, who clearly does support fee-for-service. And we've said, I think I said, that he's now trying to stop the bundled payment programs for hips and knees and bypass surgery and heart attacks, which were going full steam under the Obama administration. So I wish I could be more clear, but I think that means that we're still on the same path. The journey is going to be a little bit slower.
Mm-hmm. One other question is around the health outcomes. So clearly the Affordable Care Act and the AHCA are ways in which to enhance coverage. But as we know, coverage for health care really only accounts for the health care itself, only accounts for 10% of improvement in overall health. We have to also focus on social determinants, et cetera. So where or how will the government or private providers, pharmaceutical companies, payers, how will they come together to focus on the social determinants so that we can actually improve the health outcomes?
Boy, that's a great question and probably worth a 2-hour webinar.
That'll be the next one, Ken.
As some of you know, I teach in the Jefferson University College of Population Health. So, in fact, I'm just getting ready to start a new semester with folks in the beginning of September. And most of my students are pharmaceutical executives and doctors who are in private practice who want to get a master's degree of public health or population health or chronic disease management. I think that we've had so much chaos about payment that a lot of people haven't focused as much as they should, or as I think they should, on population health. I think that we have some really fabulous best practices, people that we can emulate. The Camden Coalition comes to mind in Camden, New Jersey. They've done some wonderful work, and actually with the support of a MacArthur grant and some other grants, have a lot of things to teach us about how to take social determinants of health much more seriously. I've been working with some integrated delivery systems who are now trying to recruit for a chief population health officer to go along with their chief medical officer. But I would say that, to look at some of the programs out of Camden, some of the programs coming out of Jefferson, there's a lot to say that we need to do, and that population health is not just figuring out who your frequent users are and risk managing them. That's part of it, but a lot of it, as you know, is as you just pointed out, getting people to understand that health is a multifactorial thing that includes your spirituality, whether you have friends, whether you exercise enough, and a whole bunch of other social determinants of health that I think we're going to need to look much more carefully at in the future.
Mm-hmm. Great, super. So I know we have just less than 1 minute left in our time with you today, Ken. So I guess what I would ask is, what is it that we as citizens, as physicians, as healthcare executives can do in this interim period to ensure that we don't lose sight of the importance of comprehensive healthcare coverage, the importance of creating some stability for those organizations and individuals that provide the care, and those companies that provide ancillary services to enhance health, such as the pharmaceutical companies, medical devices, et cetera. What would you suggest?
I think we've got to educate ourselves. And like I was very happy to see that bipartisan approach where some people on the left and right were coming together saying, here's things that you can do to at least make the Affordable Care Act work. I follow a lot of these healthcare experts on Twitter. On the right, Avik Roy and Philip Klein of the Washington Examiner, really good stuff on Twitter in terms of white papers. On the left, Andy Slavitt is someone I follow a lot. I think we mentioned that Charles Gaba, who we stole the three-legged stool from. So there are experts that you can follow on Twitter, And to be honest with you, if you look at the Wall Street Journal, the New York Times, and Vox, and maybe Stat News, you got to educate yourself. And in the words of our president, who knew healthcare could be so complicated? We've really got to make sure that the public and lawmakers understand some of the unintended consequences of things like high-risk pools or block grants for Medicaid that at first glance look like a really good solution, but there's unintended consequences that will hurt people. And I think it's our job to educate our fellow citizens and our legislators and our leaders that we understand healthcare and it's complicated.
That's a really nice place to end, Kent. And I would suggest to those of you that are still on the line, if you are looking for additional information, if you have additional questions for Kent, please do email those to us. The information in terms of our contact information is on this last slide. And we will send out the PowerPoint slides within the next couple of days. They will also be available on our website. And we thank you all very much for your attention. And Kent, to you, from the bottom of our hearts, you took very complicated information and made it easy to understand. So thank you very much.
Thanks. Have a good one.
Okay, thank you. Bye-bye, everybody.